Okay, in this next section, we're going to focus on the different features of each of the different segments of the spine and in terms of movement now. So we've already described the differences in anatomy. Now let's see how they differ in movement. So if we start with the cervical spine, there are a couple of unique joints to mention here. The first is the AO joint, or the atlanto-occipital joint, sometimes the 0C1 joint, all three referring to the same joint. It is the articulation between the atlas, C1, and the occiput, the base of the skull. This is a synovial condyloid joint which allows sagittal plane movement. The movement that's allowed here is mostly nodding. So as you say yes, that's the movement that's allowed here. It's very small and it's referred to as capital flexion or capital extension. There is no disc between this joint because there is no vertebral body for it to attach to. The AA, or the atlantoaxial joint, or C1 and C2, is the articulation between the atlas and the axis. This is going to form three joints. In the middle, we have the dens of C2 coming in contact with the arch of the atlas. This is a middle joint. The two remaining joints are on the left and the right side of this middle joint. The left and the right joints are both gliding joints, and they're the articulation of the articulating processes of C1 and C2, so facet joints. These are the three joints that are formed at the AA joint, and the movement that's allowed here is primarily rotation. Most of the rotation is going to occur right here at this joint. Now, because of the anatomy and the articulations of this joint, or these two joints, we needed to discuss some very important ligaments. The first is the cruciform ligament. This is a cross-shaped ligament. It's made up of a transverse band that wraps around the dens and a longitudinal band which goes from the axis to the foramen magnum. And this cruciform ligament is to secure the dens so that it doesn't move from C1. The alar ligament connects the dens to the occipital condyle, and it serves to limit some rotation. And the apical ligament connects from the dens to the foramen magnum. Now, I'm sure you've noticed that all these are working to keep the dens secure, and it's because this does not need to move. If the dens were to slide in any significant manner superiorly, it's going to hit a very important structure that we very desperately need, and that's our brain, the brain stem. So any movement of the dens in that direction is not good, and these ligaments, their job is to make sure that that does not happen. So we mentioned that the facet joints are what are directing and limiting the range of motion of the spine. They control the motion, and the position or the orientation of these joints differs as we move through the cervical, the thoracic, and the lumbar spines. So at the cervical spine, the facet joints are oriented in a horizontal plane up to about 45 degrees between the horizontal and the frontal plane. So as you move down the cervical spine, they go from a more horizontal position to somewhere between 45 degrees between both the horizontal and the frontal plane. When you side bend, you also get rotation to the same side. And this is because of the orientation of the facet joints. They're more horizontal and so there's a great amount of movement that's allowed. There's flexion, extension, rotation, side bend, and lateral flexion. However, the coupled movements of the cervical spine is that rotation and side bend occur to the same side. There is also some weight-bearing capability with these joints, but it's very little compared to how much mobility is actually allowed. At the thoracic joints, there are two synovial joints that are formed by the ribs on each side of the thoracic vertebra. There are 12 pairs of ribs, and there are muscles that connect these ribs and help with inspiration and expiration. The first 7 pairs of ribs are referred to as true ribs because they actually connect to the sternum. The lower 5 pairs are referred to as false ribs because they attach to each other via the costal cartilage, and the last 2 of these 5, the last 2 pairs are actually referred to as just floating ribs. The facet joints of the thoracic spine are in more of a frontal plane orientation. So in the cervical spine, we were in a horizontal plane. Now the facet joints are facing more of a frontal plane. It's this position that limits flexion at the thoracic spine, but it does permit side bending. The ribs are also attached here, of course, so that's going to limit some of the motion due to its protective function. The extension of the thoracic spine is also limited because of the slope of the spinous processes. As the spine begins to extend, these spinous processes will hit against each other and block any block a lot of movement in extension. At the lumbar spine, we start to see that the segments of the lumbar spine, as they approach the sacrum, they begin to angle more as the lordosis increases. This is a weak point in the lumbar spine as the spine transitioned from quadruped to bipedal support. L5 and S1, the lumbosacral junction, is commonly where you're going to find some of these pathologies because it's subjected to such anterior shear. The thoracodorsal fascia is also found covering this area, the lumbar spine. This acts as a huge ligament to connect the ribs, the vertebra, the sacrum, the posterior intervertebral ligaments, and some of the trunk muscles. But the function of the thoracodorsal fascia is to allow us to lift heavy objects overhead. And it also serves to stabilize the trunk so that we can throw with high velocities. Now the facet joints at the lumbar spine, as we transition down, have moved more into a sagittal plane. And it's this sagittal plane that allows flexion and extension to occur at the lumbar spine. So what you've seen is a transition of these facet joints from the cervical spine down to the lumbar spine, and it's the position of these facet joints that really dictate the movement that we have available in each of the different regions of the spine. When we talk about active range of motion at the thoracic and the lumbar spine, it's typically described together because it's very difficult to dissociate movement occurring at the thoracic spine from movement occurring at the lumbar spine. So let's move down to the SI joint now. But before talking about this joint specifically, let's revisit the pelvis for a minute. The pelvis is the ring of bone that serves to support the viscera of the abdomen. Sometimes it's referred to as the os coxae, but this is referring to the same thing. This term refers to the pelvis. The pelvis is made up of 2 innominates, and each innominate is made up of 3 fused bones. And of course, these 3 bones are the ilium, the ischium, and the pelvis. Now, we're going to use these bones again when we start measuring spine range of motion. So I want to revisit a few of the landmarks. The ilium, of course, we have the ASIS, the prominent anterior landmarks. We'll be using the posterior superior iliac spines on the posterior aspect of the pelvis. And the crests. The crests are going to be useful in helping us approximate what level of the lumbar spine we're palpating. The ischium, of course, has the ischial tuberosity, the bony prominence that is often referred to as the sit bone. That's one that we will not use for goniometry, but certainly is very important to know. The pubis, this is what will form your pubic symphysis. It's a cartilaginous joint. And finally, the sacrum is the wedge between each innominate. And the wedge is there to form that sturdy bony basin. The SI joint then is the articulation between the sacrum and the ilium. It has very strong ligaments that are holding this joint together. And these ligaments we'll list individually here. So on the posterior side, we have the interosseous ligament, and this covers the majority of the posterior aspect of the SI joint. Additionally, we have a posterior sacroiliac ligament, and its counterpart on the anterior side, the anterior sacroiliac ligament. These two ligaments together suspend the sacrum, and as there's weight bearing through the joint, the sacrum is driven distally on the ilia, and these ligaments tighten up. The next ligament is the sacrotuberous ligament. This connects the ischial tuberosity to the sacrum. The sacrospinous ligament connects the ischial spine to the sacrum, and this ligament prevents upward movement of the sacrum. So we have these ligaments that are expansive. They cover the entire joint on the anterior and the posterior side. The bony architecture in itself forms a very sturdy and firm bowl. So together we have a sturdy self-locking mechanism. As we weight bear, the bones themselves form a tight fit. The ligaments provide additional support, and we have a very strong non-moving joint. So does it make sense for this joint to move? Not really. Studies have demonstrated that there is about 1 to 3 millimeters of translation at the SI joint. There is approximately 2 degrees of rotation. Both of these are minimal and certainly nothing that can be measured by in any way by anything that we could do. So does it make sense then that this joint doesn't move very much? Of course it does, yes. If this is the link from the trunk to the lower extremity, it can't move. The SI joint has multiple variables that prevent any significant movement. Again, one is the bony architecture itself, 2 are the strong extensive ligamentous system, and 3, it's the self-locking force vectors. So can the SI joint be a source of pathology? It can, but it must be due to significant impact trauma. Normal daily activities are likely not a mechanism of injury for the SI joint. It has to be a traumatic event where there is no question as to the force that could have caused it. So if we stick to our theme of form follows function, then this being the link from the trunk to the lower extremities, it makes a lot of sense that there is very minimal movement allowed, because we can't have any distal mobility without proximal stability. I want you to think to yourself, what would be the consequences of too much movement? What if this SI joint was as freely movable as some of your other synovial joints? What would that mean to your function? So I'm going to end this one here. It's going to be a short one, and we'll pick up with the next part in a different recording.